Awkward.
Yeah. Yeah. All right. Let me
Perfect,
share.
Klifto. People on this shouldn't need too much. He shouldn't need too much introduction. As Dr. Klifto is one of the regulars on this, and somebody that we enjoy every year, and very close to many people on this call. So excited! Thank you for joining, Klifto. Really excited to have you, and thanks for sharing Cure with us for the year.
Oh, I miss him.
No, it's Kira's awesome. You clearly train him really well. So but yeah, take it away, Clifton.
Yeah. So, all right. So this is gonna be a little bit different. Like Eric said, they're all kind enough to invite me every year on this. So I think since we're all friends and everyone's so smart on this call, that instead of doing like your typical topic, because the feedback we got from our fellows was they enjoyed the conversations between the attendings and the trainees more than the actual lecture. So the initial title was fractures for reverses. So easy, Kira can do it. And the reason why I decided to do this topic was because Kier spent pretty much an entire year making a video for ASCS and ASSH. So I think I had to highlight a lot of his work, and that's where we came up with the topic for this. But I mean, really, what this title is going to be reverse for fractures, less debate to the controversial topics. So anyone who has any thoughts on any of these topics, just feel free to speak up and we'll make it nice and casual. All right. So my Emory family, and honestly, it feels like a family at this point. The way I got started really with this program is with Mike, and I knew Mike when he was a fellow and I was a resident at NYU. And what I love about Mike is what he is in this picture. He's just so good at what he does, and he's such a great leader, administrator, surgeon. But he makes fun of himself, and he wears like awful clothing, and somehow thinks a blazer with a polo is a good idea. And he allows us to make fun of him, which is why we all love Mike. So Mike calls me and introduces me to Albert Anastasio and says, "Hey, we cannot miss on this resident." So we work the back channels. We take Albert, and Albert was awesome, and we wound up trying to actually hire him back, but he decided to go to Wake Forest. So Albert, when he's here, says, "You got to meet this guy, Eric Wagner," and he's like, "You and Eric are going to be really good friends. You're very similar." And like he could not be more correct. Like Eric's probably my closest friend in the shoulder circles, to be honest with you. And we talk all the time, and it's been nothing but spectacular getting to know him and his wife and his family. So then I call Eric and say, "Hey, you got to take Kier because Kier is the most amazing resident I've ever worked with." And to that day, it's true. I miss Kier every day, truthfully. And honestly, Kier, you changed my life and how I educate and teach and how I work with residents. And you're truly a special friend. And this all leads to Nina, who is my best friend in the world now. And I could really care less about any of you at this point. So she, all right. Anyway, that
I
was
love
the
that
plug.
slide.
Best intros ever.
Perfect slide. I love
All right. Anyway, so listen, we all know the epidemiology of proximal humerus fractures. They're exploding, and specifically in the age of 70 to 75, right? Like you see by this projection, 2030, it's just going to get exponentially large, and we have to know how to treat them. So not only that, there's an exponential increase in reverse for fractures over ORIF, specifically in the ages of 65. And you can see these trends just continue exploding. Like Spiro said, reverses are going up, RFs are going down, and hemis are essentially becoming non-existent. We'll go over like some of that literature. Um, there's been plenty of studies out on is the plate superior to the reverse or is the reverse superior? And this was probably the first one that I saw. This was in JBJS in 2019. Over 65 years old, there was increased PROs for reverses, less complications, less reoperations, hardware complications, AV end of the humeral head. So this really got everyone thinking like, hey, are we really doing the right thing for patients over 65? And like Spiro said early on, like, I mean, the Hemi just wasn't a great surgery and it was very technically nuanced. So the reverse clearly, when we start looking at blinded randomized controlled trials, had superior outcomes. The crazy thing about the study is, right, like even the study showing that the reverse was better than the Hemi. I mean, 120 degrees of forward elevation. Like I hope we could do better than that, but amazingly, 80 degrees of forward elevation for the Hemi, just not very good. And abduction is just as bad. And this was the most recent study that came out just a couple of months ago. It was a Delphi randomized control trial, 5-year follow, mean age over 75. And you can see constant scores, and they look specifically at constant scores, blew away the RIF as far as outcomes go. The interesting thing about this was over the age of 65 to 74 had the most significant difference between ORIF and reverses. But interesting, 75 to 85 didn't have a big difference. So the real question is, who should we be doing these procedures on? And, we all know higher complications rates and revisions rates after secondary reverses. So it's clearly important that we have to figure out who gets this the first time and do it right the first time. So controversial topic number one, and anyone speak up. And this doesn't work if I just talk. So for operative fractures, is there a role for RFs in patients over 65? Eric Spiro, what do you think?
Yeah, I mean, in my mind, yeah, of course, there's I mean, because you and I know both share a love for nailing, perk nailing. And I've perk nailed multiple people over 65 and had really nice outcomes with it. So now ORIF in a 3 or 4 part and over 65, especially if the anatomic index involved, that's not at least in my practice, but like a 2 or 3 part with a mainly surgical neck. But it's this place. A perk nail is a wonderful tool that you can get back really quickly. I did a perk nail on a 82-year-old that had a bilateral proximal fracture. One was more of the surgical neck displaced, and one was a 4 part. We did a reverse on one side, the perk nail on the other, and she still likes the perk nail much better than the reverse. So yeah, I think there's a role.
Interesting.
Yeah, just again, in a past life, did a ton of this, and just from a historical perspective, I think we brought, I think we brought Bob Cofield down to the Southern Orthopedic Association one year. I think we were at Sea Island, I mean, at least 15 years ago. And for this injury, Bob said, "Yeah, we will plate them, and then see if we get some tuberosity union to come back and do the hemi or the reverse in a staged, you know, um, kind of situation if they don't have an optimal outcome." So, I think most people now would not be going for ORIF necessarily for kind of a stage situation. And we know the reverses are going to do better as a primary operation. At least that's what we used to say back when I did a bunch of reverses. So I think, yeah, in my mind, if it's a 3 or 4 part and there's no contraindications for arthroplasty, go for the arthroplasty.
The interesting thing is there's a lot of like the shoulder weenies out there, a lot of the conference that we were just at Spiro that are concerned that we're losing the art of ORIF because it's either non-op, reverse, and for the young patients that have proximal humerus fractures, like Eric said, maybe we're thinking of different alternatives. And I am as you know, like a proponent of nails as well. What is the youngest? Let me put it this way. Do you have an age where you would say this is too young for an ORIF or for a reverse rather? And this includes even like the head splits, right? Because that's like the biggest indication. Eric Spiro and Joanne and Kier, what do y'all think? Is there an age where you're like, hey, this is too, or for instance, like one of my partners, Tally Lassiter, if you're over 60, you get a reverse no matter what it looks like. Is that the right way to think about it? I don't know.
I'll defer to Eric, probably, who's in the thick of it now, a lot more than me. I will tell you in the IDE, for the reverse, I think, the youngest was, we weren't doing it for fracture, but she'd had a bad outcome from a fracture osteosynthesis. And we did a reverse on her. I think she was 45, 46. But we were bailing to reverse after a failed osteosynthesis.
Interesting. What do you think,
Here,
Eric?
here, Joanne, is there data looking at young patients with reverse who does poorly, et cetera?
If you're asking that, usually there probably is, but I don't know. I would be thinking anyone below, I don't know, anyone below 50 is someone, I mean, anyone below 40 is someone I would actually try to fix as much as I could. Above 40, probably not.
Joanne, do you have an answer? Kier gave a very blank, non-specific answer,
Attaboy,
so
Kier.
his
That's what I'm
doesn't
talking
count.
about.
Do you have an answer?
Yeah, no, I think Kier's about right. I think there is a study. There's a shelf life to these implants. You do get wear over time. And I think it's around 50, 52, 50, 52.
I don't know, Richard. Eric, do you have something off the top of your head, there?
Can you guys hear me? You're breaking up. So, Joanne, are you there?
Yeah.
Oh, okay. Sorry, you guys are breaking up. Yeah. So I
Oh,
mean,
sorry.
first off, there are studies looking at, and it's not just like the shelf life. It's not just like these patients are going to have revision. Obviously, if you do it early, for sure they're going to have revision, right? Because unless they die early, they're going to have revision in their lifetime. No, the more the question is they actually fail faster, and there's a certain subset that there's like two, maybe three if you count the Australian study, um, out there of people that fail faster. Like Jeffries. What's wrong with my internet? Sorry, did y'all
Yeah,
hear me?
yeah, the
Breaking up.
tail end missed.
I think you said Australian study where people fail faster.
Yeah, so sorry, I don't know what's wrong with my internet, but there is actually a couple studies. So so Pascal Below is one of the first ones to publish on it. Then there is a Mayo study. Then there was a multi-center study, and then now there's an Australian study, all looking at like age, and it's not just like that they fail; it's that they fail faster, and it's actually specific. God damn it, what's wrong with my internet?
Yeah, the best part is, Eric,
This is
that like
killing
you're
me.
about to give the punchline and we're all like leaning forward and then it breaks up. So,
I know.
It's
This
like at the
internet's.
most critical
I
point
know.
of the data, Eric cuts out, you know?
I'm like, Eric, teach me
Eric,
something. Oh, you're
we're
about
getting
to
all the
teach me something.
stuttering. We're getting all the stuttering and everything, and then as soon as you're ready to give us the pearl, you cut out.
This is killing me. All right.
Yeah,
Can you guys hear me
yeah,
now?
we can
I
hear
tried. I
you.
switched. Okay. Yeah. So it's young males, and it's males specifically under the age of 50. So young females, have not been shown to have any differences in their outcomes. Young males have absolutely had shown differences. God damn it! Why is
Yeah,
this
and that
freezing
makes
on me
sense.
so
That's
much?
logical.
So
Yeah.
I
it
just
sounds like a total knee arthroplasty, right? Don't we still say males younger than 50 have a low survivorship?
Yeah. Makes sense.
yeah.
Okay. Awesome. All right. So clearly,
Yeah, so then go back to that. So a head split in a 40-year-old here, Joanne. What's your thoughts? Like, are you gonna do a reverse or hemi on that? Are you gonna fix it?
I'm gonna try to fix for sure. Try to fix.
how are you going to fit a
What's
head split?
I
so
mean,
what's
try.
what's the, what are the outcomes of fixing a head split, Kier? There are
Probably
studies
not great
not to.
AVN. I mean, head split obviously main indication for doing a reverse and so on.
Yeah.
But
Yeah.
oh,
Actually,
okay, yeah,
See,
Hemi. Oh
we
shit, yeah.
forgot we threw the baby out with the
No,
bathwater there, Kier, right?
I know, I know.
See?
Yeah,
yeah. What Eric's referring to is that study. Was it Mortar who did that? Mortar.
Yeah.
It was that head split study showing that even with young patients, you fix it, they don't do as well. Hemis actually struggle as well, and he actually recommended his paper despite ages to reverse, believe it or not. So
Yeah.
it's just something to think about. But that was a great study that Eric just referenced there.
what
Yeah.
mortar? What's the name?
Yeah. Brother.
I can't ever say, is it Mortar? Mortar?
Oh,
Yeah, brother.
He just
okay, more odor. All
yeah,
right.
sound it out.
Patrick,
Just
right?
sound it
Is it
out.
Patrick Moroder?
Yeah.
Thank you.
Yeah. He's he's got a bunch of great glenoid kinematics stuff too. He's a big glenoid bone loss guy too.
Yeah, smart dude.
Very.
Okay. Okay. So next controversial topic. Superior outcomes with reverse shoulder arthroplasty versus non-operative management for proximal humerus fractures. So it's a matched cohort study looked at age, comorbidities, fracture morphology, followed up at 3, 6 months, 1 year. RSA patients had better range of motion, increased PROs, and lower pain scores throughout the entire study. So there's some of people I know out there who you have a proximal humerus fracture. They cite this study. You get a reverse even for classically non-operative fractures. Now, I know this is academics, right? We're not going to say everyone gets a reverse, right? But maybe I'd like to hear, Eric, what your thoughts on this and Spiro. Like there is data out there that even for non-operative classic fractures that reverses do better long term. What are your thoughts on this study?
Uh, our study on or
Getting freezing.
the
Maybe someone
Codman
who's.
study.
I'm sorry, you broke up there again, Eric.
Oh damn it! What's wrong with my hair? Gotcha. Do you want to talk about our Codman study? That's
Oh,
very relevant to this.
Gotchak's here.
Yeah, no, I mean, look, part of it is that most of these people that get these humerus fractures, that what's crazy that we found out with actually several of the common studies that we did was like the mortality after these was so high back to being better faster, relatively speaking, when you looked at the different types of fracture stuff. But there's always bias to some of these because there's always a different type of which fractures they chose, fracture patterns, and the classification systems are not easy for this. So it just varies dramatically. But we did a bunch of Codman. Which one are you referring to exactly, Wags? Because we have like I have like 6 or 7, I think, with the Codman folks.
Yeah, so
You,
no,
you,
no, the I'm talking about the fracture. We looked at mortality after fracture and humerus fractures, and we looked at like mortality, complications, readmission, hospital readmissions, all that stuff, and found that those that actually had surgery after fracture and humerus fractures actually had a
yeah, they did.
longer, less readmissions, longer life expectancy, basically less issues when you fixed it
Correct.
versus not in an older patient population.
No,
Right.
that is
Basically, it was
definitely
very
true.
similar to
I
like the
mean,
hip study.
but part
The hip,
Right. And they'll be biased in that because we're usually operating on patients that we think are gonna have a longer life expectancy, I would say, I'm sure. But Mike, Spiro, this so a patient comes in with a totally non-displaced four-part fracture, 80 years old. Are you still not opting that, or are you going to do a reverse based on your studies?
No, I know operators. I mean I still treat them non-operatively. I mean,
Same.
the problem with most of these, and I don't know who the resident was with me today, Amber was. I mean, these people hurt, right? So I have a lady who's got a slightly valgus impacted fracture, but it's certainly within the realms of non-surgical, and it's like a three-part. And these people hurt for weeks. I mean, these are miserable fractures to treat non-surgically because the patients come in, they're super painful. You have to see them back weekly. Maybe you don't technically have to, but I still see them back weekly for 2 to 3 weeks in a row. And then at the 3 week mark, I push them out to six, to the 6 week mark. But like they can't sleep at night, they can't sleep on their shoulder. There's always this small chance, less than 10% or so, that they don't heal. And they're not like I always joke, like the first day they come in, it's like they come in like looking like a mugshot, and when they're like 3 to 6 months out and they're finally getting better at the 6 month mark, they look like they're in the beauty pageant. So it's like you get to see them at their worst and then at their best once they've like recovered some. A lot of these are harbingers of other of medical issues that they have, right?
Yeah,
Right. Most of the often they fall, they got osteoporotic bone, their bone's not great, all that stuff.
Spiro, what do you think?
Oh, I'd agree with Mike. Again, I see less of this than these guys do, but the older they are, the more displacement I would accept. And again, from a historical perspective, this is probably papers you guys aren't even reading, but when I was a resident, when I was at Duke, they had a paper came out of England, and they were accepting wildly displaced four parts in these kind of relatively sedentary, petite British women, and even they ended up having pretty good um, limited goals outcomes. So I agree with Mike. The comorbidities that cause the fall are probably as much in play here as the actual fall in the fracture itself. And you know,
Awesome. Eric, anything to
I
add?
would I would tolerate a lot of displacement in the 80-year-old relatively sedate um, female patient.
When we're talking about
yeah,
displacement, are we talking about like two-part fractures that are displaced, or are you guys talking about like three-part, four-part fractures you would treat non-op that are like not that displaced? The only thing, I don't know. I'm just
yeah.
curious.
I mean, that's a hard one because like 3 and 4 parts are hard because if they don't heal, right, which they often don't, patients are having depend on their goals and their activity levels. I mean, I don't know if you were with me, but like like just like 2 weeks ago, a patient I non-op for like a year or year and a half, convinced that they should not anything, and she has many medical problems. There's no reason to fix her. And she's not high demand, super low demand. Finally, she was miserable and absolutely miserable, absolutely miserable, absolutely miserable, and just did not got no function out of her shoulder. And so finally did it, and man, that was impossible. it was so much harder doing it this far out. I mean, genuinely, like it was scarred in. The two rosters were everywhere. It was stiff. Like actually, and another example, like 6 months ago, I think early on in this, like here, I think you were Joanne, one of you were
Yeah,
with
or
me
that crazy
when we
non-union,
yeah, we're, no
malunion,
non-union, malunion. Also, another patient I tried to non-op for like nine
crazy.
months.
Yeah,
And then we did the fracture. We finally did a reverse, and then we were rotating her to kind of like put on the poly, and we snapped her proximal humerus because she was so scarred in. I mean, sorry, her femoral shaft, and they
I've
haven't
done
played her
that.
whole femoral shaft. I mean, genuinely, like those are those malunions that you do in these osteoporotic older people that you think you can treat non-op because the British, that I can't remember the name of the study, but the whatever study from Britain and the other study
Crawford
from
trial.
Canada.
Crawford.
What's that?
Crawford.
Yeah, the profit. Thank you. Profit study and all that say that you can. Fuck, man. If that doesn't work, good luck. Those are
Okay,
possible
well,
cases.
if we want to talk about the profit trial, we all know, I mean, everyone's heard the
Yeah, profit
principle.
has lots of issues for sure. For
The
sure.
average proximal humerus set that the surgery tree was one in the entire study. So if you're doing one ORF per
For
year,
sure.
there's no question about that. They're hard
So I
for
will say we had the traveling fellows from Europe come through. One of who was the author of one of the more recent non-surgical ones. He showed their stuff. I think it was the ASES traveling fellows wax that came
Yeah, it
through.
was. Yeah.
But what's interesting is that they don't just like put them in like a cuff or collar and a sling. They actually have bolsters underneath the arm for like, if it's in varus, they have all sorts of other, or pardon me, valgus, they have all sorts of stuff that they actually do that they take them to like a fluoro machine, sedate them, manipulate it, and then they have them wear like certain bolsters and other stuff that they were doing to help keep the alignment, which I just don't see done here as well in the US. Like I try to do it, but like I could never actually get anyone to actually like put the bolster under their arm to hold it out or do any of these other things to try and keep the non-op, to try and treat it non-op. But that was a whole different thing. But it's just like anything. Not most of these fractures are different fracture patterns. There's different specifics. They're not all equal depending on what you're treating. So I think it definitely matters. I will tell you that the tuberosity escape ones are the ones that do those are nasty
We'll get
fractures.
there. Save that thought, Mike. We're going to get there for controversial topic 7 or whatever it is. So,
Okay.
yeah. All right. Awesome. All right. So we already talked about this. All right. So we talked about the indications. I'll move on because like discussion has been awesome. Just real quick, everyone get a CT scan prior or no? Yes, no? That's the thing that usually I get asked. You do? Okay, good, perfect. I try and do as best I can unless it's a relatively simple fracture pattern. I'm not worried about a glenoid fracture. So I have to show this because this is Kier's masterpiece, right? He spent days
a
making these
year, a
illustrations.
year.
Yeah.
It
So
might be the
just out of respect to him, I have to show this video. This is, I'm going to say Kier's technique for tuberosity management. Three sutures through the greater tuberosity. We tag the middle one, the superior and inferior. And you can see here, that's a schematic. Another great schematic by Kier doing that. And then next we put drill tunnels. Kier puts drill tunnels into the humerus. And these are for the vertical compression sutures that really get that nice compression of the tuberosity. And then we place the middle limb through the posterior flange, the superior and inferior limbs through the anterior flanges. I use a press fit DAV seal stem, but we'll talk about that a little bit later too. Reduce the stem and then tie down the sutures. The middle suture first, that reduces the tuberosity to the stem. And then the around the world sutures, the superior and inferior limbs that go through the subscapularis and then tie down the greater to the subscap. And then there's the vertical stitches. So Mike, to your point, tuberosity management matters, right? There's been a bunch of studies below to the early stuff that if you had tuberosity healing, you would have better forward elevation, external rotation, patient satisfaction. Believe it or not, in 2018, which wasn't that long ago, there were people that were just excising the tuberosities. And I even knew, like, I don't know if you know, like Geisler, he used to just always excise them because he didn't want to deal with them. Huge risk of instability. So obviously that's not something that we should be doing. And then obviously more studies by Jane, healed tuberosities had better range of motions, constant scores. So essentially like this, the literature shows fix the tuberosities, GAMP to heal, you'll have better PROs, less dislocations, better external rotation. This was a study that I just found, which I thought was super, super interesting. Non-union of the grade 2 Rossian patients undergoing reverse total shoulder arthroplasty for proximal fractures is associated with worse outcomes. And essentially, they found that if you have a healed tuberosity versus displaced or osteolysis, right? And we all know what that classic displaced tuberosity is, right? It's the one you get the x-ray, the tuberosity is posterior superior, either because you didn't mobilize the fracture and reduce it and get to heal, or pull it off. Or the other one you see is if someone who has a real bad fracture, like Eric said, it's a little bit more chronic, there's some osteolysis, you feel like you got a good tuberosity reduction in the operating room, but you get the x-ray and it doesn't look like there's any tuberosity there. Those do awful, right? The osteolysis and displaced. Forward elevation 130 degrees, 80 degrees for the displaced or osteolysis, abduction, external rotation, quite bad. The interesting thing is we all have these x-rays if you do a lot of them. The ones that look like the tuberosity is reduced but never heals, which classically I thought, sorry, I spelled heal wrong there wrong, but classically I thought that was a bad x-ray. Looks like actually that they do pretty well. So the question is, like, what does that mean? Does it have to heal? Is it just the greater that's actually healing to the stem? Is that the most important thing? The reduction of the greater? So real interesting study that just came out. And I did this for Kier, but coaches tips for tuberosity management. Like I truly believe, and I love to hear what Spiro, Mike, and Eric think, but like Eric was saying earlier, I think the success for these fractures and the surgical management is tuberosity management. And I spend a lot of time now tagging the tuberosities early, and I spend a lot of time mobilizing them. I release both tuberosities off the humerus, and I spend a lot of time releasing the interval. I release the caps off the subscapularis. So I try to treat it almost like a typical arthroplasty for arthritis with that real great 360 subscapularis release, mobilize the greater, cokers around the tuberosity to help the reduction. And then importantly, I always fix the stem in external rotation that helps bring the greater around the front more. And I always forward elevate because that takes tension off of the greater and allows you to reduce it better. So Eric, Spiro, Mike, Kier, anyone, any thoughts on that previous study or how you manage the tuberosities?
2 words now.
Okay.
Knee knots. I'm gonna
Oh,
do a lot of knee knots. I love knee knots, and I
that's
think they're
bullshit.
great. We got.
Yeah.
Did you just say that's bullshit?
Yeah.
Love you some knee knots, but that's what I'd say. But yeah,
Okay. Does anyone have anything intelligent to say?
I mean, my 2 cents is tuberosity is the most important part of the procedure. And I think however you get it back, it's like really important to probably spend the most time trying to get them back. And the people like size them, I'm not sure if there's pretty good data suggests you shouldn't do that, especially for dislocation risks and poor outcome risks. And then as far as like getting them back, like one of the things is like getting back quote unquote anatomic, but then sometimes you have to debulk them, so I'm not sure if that matters as much as just getting back to heal, back to the stem.
Eric, can you talk about that? Like, when do you debulk? How do you debulk? Like, that's an interesting
Yeah, I
concept.
mean, it just depends on the size of the person, size of the tuberosity, all that stuff. But like sometimes when you're trying to get them back, you find them there. Maybe it's a little bit subacute. It's hard to get back. So, or it's really kind of bulky around the stem. So I want to fit around the stem. I want the most importantly the lesser and greater to be next to each other, maybe even interlaced a little bit.
Yep.
And I want them to be super secure so I can on the table range them through a variety of motion and they stay as one unit with the stem. And so if I have to debulk to accomplish that, then I'll debulk a little bit. And then especially if the earring parts had the head still on, you kind of have to take off that. But yeah, I like knee knots. I think there's a million different ways to get them back, but you got to get them back. That's clear. There's pretty good data at this point to suggest that.
What are your thoughts about over reducing them?
I think it's hard to. It's hard to get them back. So I think over reducing them is very challenging. But you'd worry about constrain them. Actually, on that topic, Clifton, I'm going to push you. Then, what would you repair the supra, the top part of the grater? Do you bring that down? Do you release the supra? There's some people, i.e. George Atwell, who wanted to do like a randomized control trial because he thinks if you do the supra, you're going to overconstrain the reverse on these reverse fractures. You don't release the supra, you're overconstraining the reverse, and you're not going to get as good outcomes.
So you
I have
think
not
you
traditionally done
release the
that.
super and leave the
I
substrate?
don't, but George Atwell cuts the supra on every one of his reverse fractors.
That seems, I mean, George is one of the smartest guys I know. That
Yeah.
seems crazy to me.
Yeah, it seems crazy to me too. But he claims that the supra is both the reverse. There's no biomechanical advantage to the supra. It's a useless muscle, and if you get to heal, especially in a fracture setting, you're going to overconstrain the joint.
I could see why he would say that. Conceptually makes sense, but the super is like, these have instability
A big
events,
part of
right?
greater tuberosity. Yeah, I agree.
And also it
That's
helps you
why
reduce the subscap, you know?
it does. It allows you to get a nice connection to it, and sometimes even put an interval suture to it. But yeah, I don't know. It's kind of interesting. And how about this, Klifto or Gottschalk or Spiro? We talk about the world has gone to lateralization. Spiro, Mark Franco was right. The Europeans are wrong. Lateralized glenoids work, it seems like, and everybody's gone to that. But this is the one where maybe there's exceptions on how much you want to lateralize. And I'm still working out, trying to figure out how much I should lateralize on my glenoids on these reverses because I want the tuberosity to heal, number one, but two, impingement free range of motion is also helpful too. So, yeah, perfect.
Yeah. I
So,
mean,
Clifton, what do you think?
so it's all about tuberosity reduction, right? And the way I think about it is I don't think you could lateralize and distalize at the same time. You could probably do one or the other, as long as you get the tuberosities to heal. And I'm just, I do worry about instability events with these patients, especially because they're usually older patients who I feel like don't maintain precautions as well. So I follow the same principles we do for anything for dislocations as to lateralize and try and create an inlay. That being said, like, I don't know. Like this study shows that lateral implants had greater tuberosity healing rates, and it said and lateralized and tuberosity influence outcomes. But that being said, if you read the study, like it wasn't written that way. This is an exact tech team that wrote that there was no difference. But if you look at their data, it did show that the lateralized implants outperformed the onlays. So I don't know. What do y'all think? I mean, there is no answer to this at all. Like this is what we really have to think about as the components change.
Mhm.
I think the
Gottschalk, what
problem
do
is
you do?
I think the problem is you can over lateralize these people because the tuberosities are not on. So you could technically lateralize them more than you should, and then you have a hard time getting the tuberosities back. I don't lateralize very much on these patients if their cuff is intact on the tuberosities, which it often is, because that's why the tuberosities break where they break.
What does that mean, Mike? What is too much? Like what implant do you not like?
I just do standard implants. I just do a standard base plate and a standard glenosphere for like a female. So it's a standard
So you
base
do a
plate.
Vermont, Gottschalk. Do you use 0 degrees of melt lateralization? Is that what you're saying?
Yes. So essentially it's a standard base plate, a 36 glenosphere, and oftentimes it's a neutral poly, and that's it. And I don't think I actually, if you get excellent tuberosity repairs, like their subscap and graders in, I don't worry about instability whatsoever because most of these people, these tiny women that you're sticking this in, I can barely get the implant down their humerus without trying to crack it. So I'm like, oh my God. So it's different for men versus women depending on what you're doing.
So what about a
Men
man?
get so a man gets a 42. I mean that's a
But
large
but
implant.
42 glenosphere, or do you lateralize?
No, I don't typically, but if I was going to lateralize or if I thought I was going to, it's a standard base plate, so no wedge. Standard base plate 42, and same type of thing. I don't typically lateralize on them, but part of it is I don't megalize them as much on the glenoid side either, hardly. And by the way, I hand ream every fracture, hand ream both the humerus and hand ream the glenoid side because the bone is often so crap that if I either let the residents or fellows use it on power, you can kiss the glenoid goodbye.
I didn't even know they made hand reamers for the glenoid. Where do you find that?
No, it's
Yeah,
not.
I don't know.
It's just the attachment. You just use a T handle on the reamer.
Oh, cool. That's awesome. That's a good idea. I don't blame you. Like I don't do something that dissimilar. I have them cob down and then it's a very light kiss, but the hand ream makes sense. Eric, component, like, I'd love to hear your thoughts on this. So, Spiro, I don't know, you said do you do a lot of reverse refractors these days or no? Okay, awesome. Just chime in if you have anything to say.
I've got very skilled partners who are experts at that procedure.
Yeah, you're a smarter man doing more elective stuff. Eric, what are your thoughts on the component selection? I'd love to hear them from you.
Yeah, I don't know. I mean, I've gone to the inlay on the humerus because I do think that it probably makes sense for the tuberosity. So I do that exclusively at this point, and especially for small females, I think it's helpful. So lateralization on the glenoid. So I'm not sure. I initially did what Gottschalk did, 36 for all females, 42 for all males, but that with the Grumman style, so no lateralization. But I've changed that recently because I do think that impacts your impingement for your range of motion. And so while you can get tuberosity healing, I think your motion is probably not as good. And so I've started doing +3 on women and +6 on men.
Yeah,
Off the
And
base plate, off the
off
sphere,
the
or
base
both?
plate. No,
I
off
do
the
as
base
well,
plate.
actually. Yeah.
Yeah.
So, but
And
let me
so I
ask you
start.
this: why off the base plate and not off the sphere, and why does it matter? Or it probably doesn't even matter, right? Because it's the same technically if you did one or the other.
Well, you can't do +6 off the sphere, but the +3 off the sphere for women, you're saying, yeah, probably doesn't matter. I mean,
The
it's
only
probably
different,
probably
the only thing that matters, interestingly enough, just for the group, is that for contract purposes, they charge you for the base plate. The sphere, it's the same cost if you use a lateralized sphere or no lateralized sphere. So oftentimes, but to your point, you can't lateralize. They don't have a +6 option on the sphere. So they do have, they have a +3, +6 on the base plate, at least for Tournier, and they'll have a +3 on the sphere side. Now they also have interesting. They do have a eccentric option too for at least Tournier, but every company has their own little tips and tricks. Exact Tech is a slightly different mechanism.
All right, Kier, you're up.
What's up? For what? Reverse? I
You
do.
read those. Yeah.
Oh,
What do you think
what?
with reverse refractors?
Oh,
I think we're talking about.
why wax is better
Or
technique?
lower trap transfers. Like,
Uh, I enjoy. I think you guys all do a great reverse and reverse refracture. Honestly, like it's hilarious, like working with everyone and everyone just being like, "This is how I do it." But like, everyone does a great job. So I love it though. I love the knee snots. That I'm obsessed with that. They're just fun to do. My hands hurt so bad, but it's fine.
The only reason I don't like the knee snots for the tuberosity repair, it's not that I don't think the knee snots are great,
Cluster. It's a
and
cluster.
they're modified knee snots, right? So that's one. Two, it's the suture management. The suture management drives me nuts watching people try and figure out which sutures are where. So like I think it's fine to do them, but then you got to freaking know where they are because the last thing I want to do is spend 30 minutes figuring out which ones go to what and what goes where and all this stuff. That's often the only reason I don't do it is because you have double the amount of suture.
You gotta be highly skilled. I think that's what comes down to. Just with the just
okay.
kidding, gotcha.
All right, let's move on. Thank you, Kier. All right, so this we talked a little about this before, but acute versus delayed management, right? These were the early studies. Systematic review showing no difference in acute versus delayed forward flexion clinical outcome scores, all cause reoperation. They actually said better external rotation delayed group. Now, again,
There's another study that debunked
yeah.
this.
Mhm.
Mike, I mean, okay, let me go to the next slide. I mean, just give me a second here.
Mike, you're reading his punchline.
Sorry.
Like there's a story. Every good lecture has a story. Okay. Anyway. All right. So Mike just ruined it. So other studies came out showing that better outcomes if you get to them less than 4 weeks, less complications. What are our thoughts on that? When do you all try and get to these? ASAP? What about the ones like Eric said that you're not sure if it's going to be operative or not operative when you pull the trigger?
Good question. Mike, you want to take it or want me to take it?
Yeah, I mean, I think each one of us may have a different answer. I mean, look, there's ones that are obvious. You're like, look, these need fixing. Then there's the ones on these people that are super, super, super sick that you're trying to figure out whether or not you should even operate on them. And then I'm typically like, all right, go get clearance. And then there's the people that go get clearance and they come back within 2 to 3 weeks. You're like, all right, we can do it. And then there's people that come back at like 3 months or like they show up and you're like, wait, who are you again? And you're like, oh, fuck, that's the proximal humerus that's like completely out of nowhere that never showed up. And now you're doing a harder fracture in a super sick patient. I think the window to me is honestly, at 6 weeks, these things can be nasty to do, and they can bleed like stink. Which is why, if people ask like, why do you use self saver on some of these? It's the delayed ones that you're kind of between 6 weeks and 3 months that you're somehow forced to operate on. If you're going to get to them, I think they are 1,000% easier, just like ORIS, within the first week or two. Once you get to week 3 or 4, you can still do them, and they're not as hard. But once you get to 6 weeks out, they are way, way, way harder. That's
Yeah.
my personal
Yeah.
opinion, having
No, I
done
agree.
enough of them.
I agree. I think if you can get to them, and Klifto, I'd be curious to your thoughts on this too. So my algorithm is changed a lot, but and actually, Spiro, you could probably relate to this because I feel like my algorithm is not that all different than some of the cuff tears that we see. But so when you look at for me, I make decision right away, op versus non-op from them. If I'm doing operation, if we're doing operation, I want to get to them as quick as I can because it's easier. The longer you wait, the more subacute it is, the harder it gets, the more painful it gets. And I do think the stiffness is harder to work through in the post-op period. So I do think you can get to them as early as you can. Now, it's not like we're doing the next day, but like within a week or so, I think is ideal. If we try to get to them as early as we can. Now, if we're doing hey, maybe we could treat this non-op. I kind of do it just like a rotator cuff where, based off the moon trial and then the other, look on the name, but my experience in this was admittedly not my original idea. This was JP's algorithm as well. But by you not up them for 3 months, and at 3 months, if they were like, "Hey, my shoulder's actually doing pretty good. I'm kind of happy with it," then you're like, "Perfect. We're gonna non-op you," and you have to commit to non-opping for the rest of the year. So you're basically at the 3 month mark. You make a decision: are you gonna do surgery at that point or not? If you say no, you have to commit to it for a year. I'm not going to touch you until at least a year after this. So you have to truly commit to the non-op regimen. If you get to the 3 year, hey, I'm going to non-op this person in 3 months, they're like, man, my shoulder sucks. I can't move it. It's terrible, et cetera, which is a little bit of a patient thing. And that's what the rotator cuff trials have all shown. It's a little bit of a patient sort of ideology or goals. But if you get to that and you're at 3 months and it's not like healing the best, and they're like, no, my shoulder sucks, then maybe you commit, and that's just a harder surgery, unfortunately. But that's like sort of the quote unquote delayed. And so for me, yeah, that's kind of my trials. I decide right away, op versus non-op, and I do feel like since I've been in practice, I've been opping way more people than I did when I first started. And it's like if we do decide the non-op, it's that 3 month thing. And that was JP's thing is 3 months and then you need to make a decision. But I mean, that's not all that different than at least how I approach if I'm going to try to non-op some cuff stuff. What do you think, Spiro? I know it's with cuff, I think we've had conversations where you have a similar sort of approach. You're sure you're on mute.
The sooner the better in almost everything. And certainly anything fracture osteosynthesis.
I think next year, if I do this again, we do cuffs. I'd love to have Spiro's take on all that stuff. That'd be fun to talk about, like chronic cuffs. Anyway, Mike, thoughts?
Yeah, no, I mean, look, honestly, the data that you have up there kind of shows it. I truly think 4 weeks or less, I can do a way better job. Once they hit 6 weeks, man, it is like just getting everything mobilized. It's like a bloodbath. And honestly, it stops once you get everything kind of reduced back again. But like, there's definitely a fair amount of blood loss in these people. What's crazy is in the last 2 months, we have had two proximal humerus like fracture dislocations in these like 80-year-olds at Grady that have had axillary artery injuries at the same time. And we just got another one, and I'm like, I don't know where these patients are coming from, or they're just noticing the axillary artery injuries, and they probably were going unnoticed before, and they were like either redo. But we have a third one, and they're like, when can you guys get to the reverse for fracture? And I'm like, well, next week's the academy. So these people are gonna have to wait 2 weeks. And they tried to put an X-Fix on, didn't work at all. The second one, they tried to put pinning, which was I give them credit for at least trying. It looked good, but it fell apart within 2 weeks. So now it's like, again, it's the same thing. So like, I told him, like, there's no way either Eric or I are going to get to this until after the academy. And I told him it has to be done at a place that has a vascular surgeon, which is not our typical orthopedic hospital.
I think that they're fixing that one either today or tomorrow.
I bet you they're not fixing it.
No, no, she's in there. I think she went today, maybe. Blair was it's like they talked about it today in conference.
No, we canceled it.
Oh,
Getting
it
a
canceled.
gotcha. Yeah.
Oh, there
Yeah,
you go.
but I was going to say Blair reached out to me today to say that that the patient needs that. She's 80 something. I think you put a plate and screws in it, it's going to pull out everything. And then you have a lady with an axillary artery injury that you've pinned, failed, plated, failed, and then you're going to get a reverse. So, I mean, the ultimate, I think, Jason, I think we're going to do a reverse on her in 2 weeks is the plan.
That sounds
Yeah, that's
appropriate.
good. That's good to know.
So
And she
okay,
has to re-bridge, right? You gotta, that's the other thing is the last one I did, we did not bridge and we lost 1,000 cc's. That's when Alex Webb goes, Gottschalk, do you care that she's on Plavix and Lovenox? I said, of course I fucking care. That was like are we being recorded, by the way? Yes, perfect. Great. So I was like, Webb, of course I care.
can we edit that part out if we're all right, anyway. Listen,
This is going, this is going straight to Viewmedi, guys, right? We're streaming straight to Viewmedi.
this is the last time I got invited to be back here. But I, the interesting thing about this study is the intraoperative complications over 28 days, like Eric said, go way up, right? There's callus around the humerus. You have some scarring down. They had periprosthetic fractures. And again, it comes to mobilization of the tuberosities. Like Keir saw me do it when I was here. Like if I had a reverse for fracture to come in, I try to get within 7 days, no matter what, whether that's going on a Saturday, canceling the end of my clinic, whatever it is, trying to get these, it just makes your life better. You get a better reduction, and better outcomes. I can't wait to talk to you all about this. STEM management, right? So we know that STEM healing matters, right? Again, this is Levy's black and tan technique and super innovative, right? For those of you who don't know what the black and tan technique, you kind of see on the right side, you pod the humerus, you cement it, you don't cement the top portion of the humerus, you repair the tuberosities, hoping that the tuberosities will heal and you'll still have a cemented stem distally. And I mean, the outcomes are great. Tuberosity healing rate of 88%. That's higher than a lot of the studies in the literature. Again, forward elevation, I think this is an older study. We're better at it now. I'm not happy with forward elevation of 117 degrees, but when he came out with the study, it was a really nice technique. And since then, there's been a bunch of studies coming out on uncemented constructs. And with a lot of the new stems out there, it seems like that's where the market's trending. Uncemented constructs have really, really good results. 97 achieve stable fixation. 70% had healing tuberosities, right? So maybe we're not as good as Levy's study, but ASE score is good. Simple shoulder test score is good. And this was a study that just came out that showed non-cemented had higher than black and tan, that had higher than cemented. So Eric, I know you cement, right? I'd just love to hear, you're always
I
so well
do
thought
black
out.
and tan.
You do, okay, you do black and tan. Okay,
I do
awesome.
black
Yeah,
and tan.
both Wags and I both do black and tan technique, which technically that is a cemented stem. It's just not cemented all the way up to the tuberosity. So, I mean, I can't imagine when they say cemented versus black and tan, I'd love to know what the difference is because I can't imagine someone cementing all the way up to their tuberosity repair.
It was a crappy systematic review. They didn't even know what the differences were. But yeah, no, I agree with you. I'd love to hear on your thoughts on why you do black and tan, how you do it, what the technique is.
Yeah, I mean, here's my 2 cents. Is like, the hips went through that revelation of cement going to uncemented on these fractures, and they went back because of the long-term outcomes of them. So from my perspective, I think it's probably going to have the same thing here, but maybe I'm wrong. I do know my complication rate with the stems with the black and tan is like 0%, meaning that like if I'm treating an acute fracture, I'm never going to have a periprosthetic fracture. It's like truly impossible. And I do feel, especially if you clean out the cement, that's the idea. So it's really important to cement distally, but then be really, really vigilant about making sure there's no cement anywhere near the tuberosities. And then packing bone graft from the head in there, and you can get a really nice tuberosity healing. I mean, the tuberosity healing rate is we have not looked up our own outcomes, but I anecdotally seems like it's very high. And I just don't. I guess for me, if I want to fix a problem that I'm having, and I'm not having a problem with the stems on the humerus, and they never loosen. I never have intraoperative complications, and the tuberosities heal very reliably. So I'm like, why would I then go to something where I'm like treating an 82-year-old female with osteopenia or osteoporosis with a press fit stem that if I don't get the tuberosity healed, then is gonna be fixed primarily in the diaphysis and then stress shield away over the next 5 to 10 years. I mean, for me, it just doesn't make sense logically. It's not something I've jumped on board, even though the entire ASES I feel like is jumping on board to this. It's not something that makes a lot of sense to me. So it's not something I'm like super excited to jump on board. And Clifton, I love jumping on board on cool, innovative things. This is just not one of those that makes a lot of sense to me. But
I think they're
gotcha. Do
appropriately.
you have
I
thoughts?
don't, you know.
Yeah, so I think, part of where this came from, right, is the same thing in hips, right? Where they were trying to decide whether or not they were going to cement hemis or do press fit hemis in these folks. And they just noticed a higher fracture rate when they were press fitting them. The issues when they were cementing is that, which I think is a little bit different in femurs because of the size of the femur and the radius of the femur itself, right? You have this very large door C type femurs that they were putting in, so there are higher issues of cement issues. You just don't see the same cement issues of like pulmonary emboli and all the other stuff that you get in the humerus. I bet you the rate is drastically reduced in the humerus than it is comparatively to the femur because of the radius is so different and the size. I just don't think you see it. I mean, knock on wood, I personally have not seen it. It could also be that just the sheer numbers are so much lower than the number of hip fractures. I don't know, but I just, yet again, I have not. Part of it is maybe we're not super pressurizing the humerus either in comparison, and it's like, look, you just lay it in there, and the truth is, if you get the tuberosities to heal plus the little bone graft that goes in the middle of the stem, which we love, it works great. Now, I will tell you, there's the newer stems that allow all these screw fixation into the humerus distally and all that stuff. Interesting. I reviewed papers for JPS on all that stuff, and the rates of healing and issues were higher than just the plain old stuff. I mean, I just don't know that. To Wags's point, I just don't know that you fixed the problem or if there actually was a problem. But
Yeah,
I'm a
Clifton,
black
what are
and
you, what are your
tan
thoughts? Clifton, have you gone to uncement? Have you gone uncement? I think you have, right? Or no?
I'll do if I can press fit it, I press fit it, and if I
Yeah.
feel like I need to cement, I will. I'm gonna always try and press fit first, but I'll do whatever it takes to help the patient. The interesting thing about press fitting, and Kira's seen this, I would say probably 5% of my stems. I do a ton of reverse refractures. I'd say probably 5% of my stems shift a little bit when I press fit them. And whatever reason, whenever that happens, like it almost looks like they're too anteverted or retroverted, or whatever it may be. They have better outcomes that way. Like it almost like settles into like where their shoulder wants to be. And like the x-rays look awful, but the range of motion's amazing. I can't explain it. Okay, we have 3 minutes left. I have to ask this question because this is the number one question that my trainers always ask me. If you're cementing, how do you set your height when you don't have tuberosities to reference off of? Eric, Mike, how do you do it?
Then could I ask you, if you're uncementing, how do you set your height? I mean, it's kind of the same thing, cementing or uncementing, right?
No, I always set like Kier knows this. Like I always cement it high, like really high. Like I put it like at the level of the glenosphere, and I try and get a zero poly in every time and try and get stability. So like I just reference it off of the glenosphere.
So I
But
try. I mean, I
So then
try
you
it.
have no cal. Wait. Sorry. I want to push you on that, Clifto. So then you have no calcar because a lot of these don't have like the fracture way the fracture set up. There's no calcar. So you're cementing them high. You're putting the tuberosity around the back, but then the front has no calcar support.
yeah, I mean I reference off of where the glenosphere is.
Yeah, that's what I'm saying. So if you're just submitting it high, that means you're probably leaving it a bit proud, and so that
Yeah.
means that you're okay with doing it uncemented without any calcar immediately.
Yeah. Yeah, I'm okay. And I reference off of the height of the glenosphere. It seems to
Ah,
work out really well. I almost get a
interesting.
zero poly in every single time, and it just works. It works really well.
So I think there's two different types of patients when you talk about this. There's one who's what I call the LOL, the little old lady, who can barely even take the smallest stem that you have. And so you're putting the smallest stem in every time. And essentially the stem is sitting on what's left of the calcar, if there is a calcar or whatever's left. Like you can't impact it any further because that's as low as it will go. And it's often like it's a tight fit every time for those folks. Then there's the folks that actually have a significant, like larger humerus that you actually have to plane a little bit. But there's all the studies. I'll typically, most of the stems we use, they have a measuring device. So I look at the 5.6, 5.8 centimeters from the superior portion of the pec to the top of the stem, and that's often pretty reasonable. So what I actually is I put the stem where I think it's going to be based off of the calcar to see how well it's going to fit if there is one, and then I measure, and if it's close enough, I'm like, hey, this is good. But then I trial it, right? So I put it in as non-cemented first, and I typically want, to your point, I want a zero poly. I can't remember the last time in a reverse for fracture that I've actually had to put a non-zero poly, like I've had to go up on poly.
Unless you
Almost never.
unless you cement it down or press fit down to the calcar, and then you're kind of at liberty of like where the calcar is and what the soft tissue tensioning is. In my opinion, that's just why I did it. But Eric, you seem to reference off the calcar. Do you
Yeah,
have
so
like
I reference all the time with the calcar if I can. I put it down hitting the calcar. I went into the calcar. I've never actually had that, but I can't think if I've ever. I don't think I've ever had to put in plus poly to this point that I know of. But that has been. I do think if you get, I don't really care so much about the stability because I think it's going to be stable to Togarasi's heel. So for me, I would trial just because I want to make sure I can reduce it. But I honestly, if it's loose, I could care less. I think. So I reference out the Calcar. I put the sim down to the Calcar, and then I reduce it because I'd rather it be a little loose than a little tight. And the little ladies are always tight, regardless where you put it. I would sink this in as much as I can because those ladies are going to always be tight. A little bit bigger ladies or men, from my perspective, it's a little more loose. But I actually rather this type of situation be a little loose because I think they all get stiff or they all are going to get stiff as the heels. And if the tuberosities heal, they're going to get decent motion. And especially now that I'm lateralizing, I have to make so yeah, it's not often I put in a plus. I don't think I've ever put in a plus. I don't like truly. I don't even think I trial for a plus. If it's loose, I don't really care. And I don't think we have ever, and we do know this data. I don't think we've ever had dislocation after reverse for fracture done at Emory in the last 5 years or 8 years. We just built a big reverse database, so we actually do have that data. And we've not had dislocation. I know that we've had other complications after reverse fractures, but not dislocation.
well, Kier still has 6 months left, so there's still time.
That is true.
So in conclusion, it's 9 o'clock. Who knows, right? We still have so much that we have to figure out reverse for fractures. And that's why I chose this topic to kind of screw around with y'all. But thanks for having me. It's always a blast.
No, this is a
Clifton, you're
great,
awesome,
great
man.
talk, Clifto. Great discussion points. Only thing I'll tell people or our trainees is that it's so funny because everyone's like, oh yeah, no, so and so doesn't want to do the reverse for fracture because they're worried about the glenoid. I'm like, the glenoid's not the difficult part of this case. It's the tuberosity management, which I always think is very interesting because the glenoid's a wide open view. It's the best view you ever have of almost ever looking at it. You don't even need a release inferior capsule, which is something we didn't discuss. But like, I don't mess with any of the capsule or any of that stuff typically.
I do because it helps me with my tuberosity mobilization.
Yeah, we talked about Mike. You just showed up late for my talk. Thanks. Hey, Mike, real quick question. You have two computers behind you, but you're on a computer now facing you. How many computers do you have in your office?
Just two.
Okay.
What are you on right now then?
What are you
I'm on a 55-inch curved monitor. I converted my office when we were doing COVID telemedicine, which my whole family was like, you're never in your office. Why do you even have an office there? You never do stuff. And then when COVID hit, it was like all bets are on. I upgraded everything to actually be able to sit and talk to patients and do everything. But the truth is the computer behind me is a PC. I'm on a Mac in front of me. So we
Mike,
have one for each.
you're the Neil Peart of computer monitors. You're 360 degrees.
Yeah, I usually do your talks with like a headset and just
And if you guys know that reference, kudos to you.
Rush. Yeah. So
My man.
At Duke, we do it this way.
I didn't say that once, did I?
At Duke,
at Duke we don't cement. I'm just kidding. Oh wait, Tom, did you guys tell Clifto? Sorry, I know everyone has to go. Did you tell him about the Staples incident? Literally, like I was asking to like put Staples in, and they were like in another room. I was like, "Can I put Staples in this?" And I think it was I don't know if it was Gottschalk or Wagner.
Gottschalk.
Like, this isn't fucking Duke, bro.
It was Gottschalk. Gottschalk. So somebody came into the room and we're doing elbow EPC. Somebody comes in the room, Gottschalk and we're working on this elbow EPC or no, we just in this elbow EPC.
Yeah.
And we actually Gottschalk was we were doing a stage grafting on this bad glenoid deformity, and somebody walks in and is like, "Hey, Kier wants to know on the elbow EPC if we can use staples." And Gottschalk goes, tell him this ain't fucking Duke. Duke, use staple. I mean, use sutures.
Staples were great for the elbow.
Don't worry, we're still recording. So
Somebody's got to take the staples out. That's the problem, right?
I know.
Yeah.
They're going so good though.
They're going
so
nice, but somebody's got to take them out.
Joanne takes your staples out, right?
She helps me.
Yeah. I actually take them out in the OR when there's a wound complication.
Oh.
True. That's good.
It never happens.
All right, now thank y'all very much. Thanks for spending the evening, Klifto. Phenomenal
Thanks,
job
Chris.
as usual. We love having you.
Thanks,
Yeah,
buddy.
Get
thanks
ready.
for having me. It's
Think
always a
about
blast.
your topics for next year.
It's going to be controversies and cuff.
I
Yeah,
love
we
it.
already know what it's going to be.
I was about to say, Chris, we'll actually see you on Sunday.
Yeah. Oh, no, I'll see you at the end. My flight gets in right when you guys are finishing.
So
Okay.
I thought we were having dinner on Sunday. You're not coming in for dinner?
Yeah, I think the only flight I could get is like right in the middle there. So I'm going to take a cab right to y'all as soon as I land. I'm not even going to go to
Okay.
the hotel.
Fair enough.
Yeah. All right. Anyway, see y'all Sunday. See ya.
See ya.
See you guys.